The Pentacam is really our method, our tool for screening our patients in cataract and refractive surgery. Here my financial disclosures, I consult for OCULUS, and we worked with OCULUS over the years on several studies, several devices here. And as Michael pointed out, we're looking at cataract procedures nowadays. The expectations have gone up, particularly when you look at the premium IOL area. And if you have premium IOLs, for example, presbyopia correcting, patients need really extensive biometry because you need to have a good outcome. And the more we can put into it in the preoperative evaluation, I think the better the outcomes will be. Just for you a little bit on the Fluke tomographer, just one slide demonstrating actually here what is done. You get a screen of the anterior segment. As you can see here on the right side, the Fluke principle comes a long time away. It was invented many years ago, and I can remember my residency time in Bonn, Germany, where we actually had Fluke tomography or Fluke devices to look at lenses for screening pharmacological agents. Now, what you see here is basically a picture is taken from the anterior segment, and then bringing up this picture of the anterior segment. As you can see here, this display which provides you with a lot of information. Now, we have done some studies, and because the map of the anterior chamber is taken, you have a more accurate model of the cornea, thickness, and the posterior surface. And to assess total corneal power with the use of ray tracing is basically one of the principles here which you use with a Fluke tomographer. Now, we have done a couple of studies very quickly. Densitometry of the natural lens published in Journal Cataract Refractive Surgery. You see this on the right side. In the old days, we have subject cataract staging. We have objective staging now. And we did a trial, prospective evaluation with intraoperative reliability very quickly. And we found, we looked at the analysis models of the anterior segment. You can see the cornea and you see the lens. And what we found is basically outcomes published in 2014, that we had a high repeatability. 3D was better than the 2D, and the peak, as you can see on the right side, with an increased scatter results in decreased repeatability, however, and repeatability decreased with increased opacification of the lens. Now, we have used this for very shortly, very quickly, we have used this in femtosecond laser technology, flex, and lens opacification. This is a paper we published in the American Journal of Ophthalmology. And what we found is here that basically looking at the Fluke lens densitometry, we had a very good method to compare phacoemulsification energy versus phacoemulsification plus femto, or femto plus phaco. And the outcome was basically in 150 eyes that flex had a lower effective power time than conventional cataract surgery, and the EPT correlates positive with the preoperative lens opacification. Now, this gives us maybe a tool in the future to look at the pre-op screening for our lenses and then basically change our settings in the machines for cataract surgery. I think this is a very interesting idea. We wanted also in a study we just have accepted for publication, we wanted to know whether all these the different patterns of the femtosecond laser matters. We did a retrospective analysis, 75 eyes. Lens opacification was measured pre and with the Pentacam densitometry zone. And what we looked again at the effective phaco time. Now, the outcome here was interesting. Overall, we had favorable results for the grid pattern. The grid pattern you see on this slide on the left side basically had more cuts with the femtosecond laser than the pi. And this, again, comes to the outcome that we basically can, in the conclusion, in general, grid pattern is superior. However, in eyes with high lens opacification, the pi pattern should be considered. So what I'm saying here is, again, if you have the densitometry, you can basically work on your settings for surgery. Now, why I say this with Oculus, I think this device is going in this direction. Michael Balin pointed out the corneal power. You can see here the tangential, the sagittal, and the total corneal refractive power. And the concept, now that we don't take just the anterior measurement, but also the posterior measurement into consideration, is very important. Here just the example of what we usually do in the topographers. We take tangential or sagittal maps. You can see here the principles. And the total corneal refractive power map includes basically all of this. Now I give you an example of this slide here, which at the end demonstrates the following. We had the anterior surface measured, and it was a 2 diopter SIMK astigmatism in this particular patient. When we looked at the total corneal refractive power, we found 2.1 diopters. So the difference here between the SIMK you could also take with an IOL master or with a keratometer with 0.1 diopters, so very small. Here's another example. SIMK actually showed 0.1. That would you have with an IOL master or with any other device, but the total corneal refractive power is 1 diopter. And we have to evaluate this because, as we just talked about, the underestimation of astigmatic component against and with the rule, I think this is very important. So we had here a difference of 0.9 diopters, and that would have maybe, we would have chosen, or we had chosen here, the lowest toric IOL available. Now, repeatability, I think, is very important. We did a study in 2016 where we had prospective case series of 45 patients, corneal astigmatism up to 3 diopters, and we measured with 5 devices with different measuring techniques were compared. 2 measurements with each device was actually done, and the outcome of this study, you can see here. We found the low coefficient of repeatability means better repeatability overall. The Fluke SIMK measure showed the highest repeatability in this study. So with all the devices we compared here, the IOL master, we looked at the topographer, we looked at the keratometer, and we also looked at the Fluke. And you have to go into detail this paper if you like. The Fluke had the highest repeatability in this study. For total corneal refractive power, repeatability was best in the 4 and 5 millimeter zone if axis was also considered. That was the outcome of this study. Now, the Pentacam AXL is a device which basically has now 2 devices in one. And as you can see here, while I'm talking on this slide, you can see what all the device, or what the device has basically. IOL power calculation, Fluke imaging, 3D interior chamber analysis, pachymetry data. I think it's very important. If somebody looks at an eye and cannot access the pachymeter or has to measure with another device the corneal thickness, that's time consuming. You all get this in one measurement, basically 3D cataract analysis, phakic IOL simulation, for example, the Bale and Ambrosio enhanced ectasia report, holiday report, tomographer, cataract pre-screening, indices, and corneal display. And all this is done in a very short period of time, 100 Fluke images within 1 scan in less than 2 seconds. And now we have a combination with an AXL, which means axial length measurements. And the axial length measurements, you all know this principle from the PCI, the biometers, which is available, the partial coherence measurement of the axial length, which we know from IOL master technology is a very precise measurement. Now, just this year, we published a comparison between 3 devices, actually. A prospective case series, 79 patients. We did previously a retrospective study, but we wanted to do this on a prospective manner. Therefore, we designed this study, and we looked at 3 devices, the IOL Master 500, the IOL Master 700, this is a new device, and the Pentacam. And we did 2 measurements with each of these devices, and the outcome is repeatability. Here's a busy slide, but if you compare them overall, it's IOL Master 500, one versus the second measurement, and the 700 and the AXL. And what we found is that no significant difference in axial length measurement between Pentacam, AXL, and the IOL 500, as well as the IOL 700. So that's a very important information. So we had a measurement which basically is here in terms of repeatability, giving you the same results. Furthermore, recently introduced Pentacam software designed to also get past very dense cataracts. That's important information because you want to also get good outcomes of these patients. Michael talked about this toric IOL calculation printout, just one slide here, and of course you have to look into the machine, but basically The calculation which is in the Oculus software now takes into consideration total corneal refractive power. Like Michael pointed out, for example, Graham-Barrett's formula is an estimation of the posterior power, but this device takes this into consideration because it can measure it, because you have that chime Fluke technology. And Oculus has incorporated this in their tools, and it's very important for toric IOLs, I think. Very shortly, we don't want to talk about the cornea, but overall, we also did a chime Fluke study on evaluating corneal cross-linking, and basically used the Bell and Ambrosia to look at this. And we found also a very valuable tool for screening different areas for pre-treatment, accelerated versus corneal measurement with the usual cross-linking. Both methods showed to be effective in halting progression overall. This paper is also submitted. And I'd like to conclude, for the Oculus device here, the lens opacification should be measured preoperatively in patients undergoing flex in order to choose the right pattern. Can be a statement. You don't have to do it. But I think we basically go in this direction. Chime Fluke measurement show high readability when it comes to corneal evaluation. There was no significant difference between the Pentacam AXL and established biometers for measuring axial lengths. It's very important information, as you can see, published 2017 in AAO. And finally, chime Fluke technology can be used to track effectively of corneal cross-linking in eyes with keratoconus, just as one example of using this device for not only cataract, but also for your corneal or for your refractive data. So for me, the Oculus Pentacam is actually my device where I screen all my patients in cataract, refractive, and corneal surgery every day. Thank you.